All right, so we're going to continue in this section, just talking a little bit more about some of the changes and then some more of the specifics about teaching that we need to be doing with our moms. So the prenatal period, this time where she's pregnant, it's a time of tremendous change, emotional change, the physical changes that go along with the pregnancy, and then getting prepared for the birth of this baby, for parenthood and what that means for this mom or this family, and how they're going to incorporate this baby into their structure, whether that's the family structure, whether that's how is mom going to relate to her friends who have other kids, or her friends that are single and don't have kids, or how is this going to affect her relationships with everybody she has at work, her friends. And so this is just a normal change of all these different emotions and ideas that mom's going to have. So some of the nursing care that we're going to do, we're going to have certain diagnoses that we use very, very frequently throughout this pregnancy. As we talked about in the last session, constipation due to those physical changes. Almost every pregnant mom complains of constipation. They're going to have a knowledge deficit. And again, I want to challenge you to think about these changes in women going through this phase of pregnancy. Pregnancy is a normal lifestyle life event. It is not an illness typically. And so we don't expect all moms to know what to expect during pregnancy. We don't expect all moms to know how to come out being champion breastfeeders or to know exactly how to tolerate labor and delivery. And so yes, it is a knowledge deficit, but this is a normal change. So how about readiness for enhanced knowledge, readiness for enhanced family processes, and readiness for enhanced knowledge related to the childbearing process, readiness for enhanced breastfeeding. These are normal changes. So let's put a positive spin on some of our nursing diagnoses. And then a lot of the nursing care that we're going to do is anticipatory guidance, which is also another fancy way of sometimes saying education. Here are the things that might happen during your pregnancy. We know that women get nausea and vomiting. We know that they get constipated. So we're going to want to teach them about all those things and not wait for them to have to call us and I'm so constipated, I don't know what to do. Let's teach them early so they can be active participants in this lifestyle change that they're going through. The priorities of our nursing care are going to be based on the woman's most immediate needs and sometimes the fetus's most immediate needs. The most common interventions that we're going to use with our patients and our families are communication techniques and teaching. We're going to identify risk factors and other deviations from the norm to enhance the pregnancy outcomes. We're also going to identify some of those normal changes so that we can teach her how to enhance the pregnancy outcomes, such as nausea and vomiting. We talked about that last session. We're going to talk about it a little bit more this session because it is such a common thing in pregnancy. Don't wait for her to call you and tell you that she's got nausea and vomiting. What do I do about it? By talking to her early, we can enhance her pregnancy outcomes. If we talk to her and teach her how to self-manage some of her nausea and vomiting, maybe we can prevent a nutrition issue. We can prevent her having to be hospitalized because of dehydration because she's not eating and drinking. We can ensure that the baby's getting the nutrition that they need. So not only are we identifying risk factors, we're identifying those normal common things, and we're teaching mom how to help manage those so that we can enhance our pregnancy outcomes. We're also going to identify preventive aspects of healthcare. What are the things that we can teach you that are normal changes and how do you manage those? What are some of the things that we want you to avoid so that you can have better pregnancy outcomes? What are some of the things like getting your flu shot during the pregnancy to enhance your health and to enhance the healthy environment that the baby's going to be born into? We're going to motivate our moms to practice optimal self-care. Sometimes that's like we've been saying, this is a matter of education. Sometimes our moms don't practice this optimal self-care because they don't know what they need to be doing to do that. And a prime example is we have a mom that comes in and she's had 2 or 3 urinary tract infections. And when we talk to her, we ask her, are you wiping front to back? You'd be surprised at how many women don't know that. They haven't been taught that. They don't know that they're causing these infections based on the way that they're wiping. And so we need to teach them how to maximize their optimal self-care. We're going to assess, and we're going to talk about that in our last session for this week about nutrition. We're going to talk to them about relieving some of the common discomforts of pregnancy, which is what most of this session is going to be about. Some anticipatory guidance, assessing what their support systems are. Do they have the support they need? Do they have stable housing? Do they have safe housing? Those type of things. And then if not, involving the appropriate individuals in helping teach them and helping them seek those resources that they need. Assessing and supporting cultural approaches to care. Our medical model in the United States tends to be a Western model of medicine, and it tends to be fairly universal from north to south, east to west. And we know that we have a huge cultural variation all across the United States. And so we need to be assessing and appreciating our clients' cultures, because the way that they approach this pregnancy and the way that they approach health care in general and self-care can be very impacted based on their culture. So the initial assessments in this current pregnancy, we're going to find out when was the first day of their last menstrual period. Determining the accurate due date, the accurate gestational age, is crucial to ensure that we are getting all of the exams that we need to have, that we're getting all the laboratory workups that we need, so that we can help ensure a healthier and safer pregnancy. We're going to see if she currently has any problems. She comes in for her first prenatal visit, and she's been throwing up nonstop for the last week and a half, and she's lost 10 pounds. This is not good. So we need to not just teach her about all the safety things and all that stuff out there in the future, in future weeks and all that. This is a real emergency that we need to handle right now. And then we're going to look at her OB/GYN history. She have a history of infertility. How many times has she been pregnant? What were those outcomes? We talked about those kind of things last time. And what's her GYN history? You know, she's had part of her uterus removed, or she's been treated for cervical cancer, which has great impact on the health of this pregnancy. We're going to look at her medical history, what her current medications are, what her current herbal supplements are. We're going to look at her family history. We're going to look at social, experiential, and occupational history. Not all the jobs that we have out there are safe for all of our pregnant moms. Some of if she's exposed to heavy metals, that's probably not healthy. It's not healthy during pregnancy. So at her first prenatal visit, she needs a complete physical exam. And that's a breast exam, that's doing a pap smear and a pelvic, and just the complete physical top to bottom to make sure mom is in the healthiest condition she can be in for this pregnancy. And if she's not, let's get her there. Let's get those things taken care of. She's going to have a complete set of lab tests. Now, depending on the practice, she may come in for that physical, then they send her for all these labs after the physical. Other practices may go ahead and do those labs so that those results are back when they actually come in to see the doctor. So they're going to get a complete blood count. We want to see if she's anemic before she starts this pregnancy, or in the beginning part of this pregnancy. We want to know if she has signs and symptoms of some type of infection somewhere. We're going to get a glucose. Now we're going to talk about glucose much more when we talk about our high-risk conditions, but I do want you to look at the glucose section in your textbook. Not everybody gets a glucose at their first prenatal visit. ACOG recommends based on risk factors but a lot of the physicians do A1C, or they'll do a fasting glucose. So there's some variation there. Just kind of look at that in your textbook. Then we're going to find out what their blood type and what their RH is. A positive, O negative. And then this antibody screen, they're screening to see if she has any kind of antibodies in her blood related to the ABO-RH factors in her blood, because some of those can be very detrimental to our fetus. We want to know if she's been exposed to rubella or if she's gotten her rubella titer. We hope that all women are rubella immune when they get pregnant, because exposure to rubella while she's pregnant can cause a fetal death, it can cause a lost pregnancy, or it can cause massive scarring and neurologic damage that cannot be overcome. We want a VDRL and an RPR. Those are tests for syphilis. HBAG, that's hepatitis surface antigen, and that tells us whether mom's been exposed to hepatitis or not. And then if she has this antigen, then they're going to do further testing to find out if this is an old infection, a recovering infection, a current infection. So this is just a screening to help tell us whether we need to do further testing. We're going to do an HIV. And I believe that the law is still current that HIV can only be done with consent, but we typically try to ask all women to give consent because we want to know that status while we're doing the prenatal labs. We do know that if we treat mom with HIV, if we give her antivirals while she's pregnant, it decreases the transmission risk to that fetus. She's going to get a pap smear, make sure we don't have any cervical cancer. It's going to help tell us whether we've got infection, whether we've got cervical changes that need to be taken care of, or if they're the type of changes that can wait until after the pregnancy. GC, gonorrhea. Tell us whether she's got gonorrhea, chlamydia, HPV. All pregnant women are going to get a urinalysis. A lot of our pregnant women have asymptomatic bacteremia, and they have group beta strep in their urine. A lot of us are exposed to that. A lot of us are carriers of that. And it doesn't bother us because it's kind of normal flora for us. But if they have group beta strep in their urine or in their vaginal tract, that can cause preterm labor and it can cause newborn sepsis. So torch titers are discussed in your textbook. I want you to look this up. I want you to see what they test for. And all pregnant women, they will either have the results of this all written out with each one of these disorders listed, or they'll say torch titers were negative. Frequency of visits for our healthy moms, every 4 weeks until 28 weeks gestation. Then after 28 weeks, we're going to see her every 2 weeks until she's 36 weeks along. And then after 36 weeks, we're going to see her every week until she delivers. Now, if she has any form of complication, if she has any form of prior history, then that's going to alter this frequency. Say that we had a previous fetal preterm labor at 29 weeks. We're probably going to start seeing her more frequently earlier on. If she had a history of a fetal demise at 30 weeks, we might start seeing her at 30 weeks. We might see her every 2 weeks, or maybe even every week at that point. So our first prenatal visit, we talked about all the things that we're going to do. And then in all of our follow-up visits, the things that we're going to do at minimum, we're going to do a vital sign. We're going to do maternal weight. We want to make sure what that weight gain is throughout her pregnancy. We're probably going to do a urine dip, and we're going to see if she has any protein or if she has any glucose in her urine. And if you'll remember from our last session, we talked about a trace amount of glucose and a trace amount of protein is normal. Any more than that, then it requires further follow-up. Our fetal assessment that we're going to do every week, we're going to ask mom what sensation she has. We hope that mom is feeling fetal movement at a certain point. And then after that point where she feels this fetal movement, we're going to ask her every time, is baby still moving? Like, what is normal for this baby? We're going to figure out a gestational age. We're going to recalculate that, make sure that all the data still points to this is the true gestational age. We're going to do the fundal height like we talked about last time, just as a non-invasive way to determine that we've got adequate weight gain and fetal growth. Leopold's maneuver, and I apologize for that on this slide. I'm going to remove that review how to do this tonight before Smart Hospital tomorrow, because that's from the lecture for the on-campus group, so I apologize for that. So every visit, we're going to listen to fetal heart tones, FHTs, and that's listening at one point in time and saying that for this point that we're listening at today's visit, this baby's heart rate was 137. As opposed to a range if we have mom on the monitor for a longer period of time. We're taking the baby's heart rate. We're going to ask for quickening, and that's when she starts feeling fetal movement. That helps us age this pregnancy. We know that women cannot feel fetal movements when she's 8 weeks along. So if she comes in and she's telling us that she's having fetal movements, but based on her last menstrual period, we determined that she's only 8 weeks along, then we need to do some further investigation because that does not make sense. And then our anticipatory guidance and education. What's coming up? What are some of the signs and symptoms? What are some of your discomforts? Tell me how you're feeling. These are the things that we're going to do at your next appointment. These are the things that you might start experiencing before your next appointment. So now let's talk about some of the common discomforts of pregnancy. I'm going to try not to be redundant from the last time, but I am going to go in just a little greater detail. We said last time, nausea and vomiting. Almost everybody has heard of morning sickness. Sometimes this is the most severe sign and symptom that our pregnant women have. 70 to 90% of women experience nausea. Now, that's just a queasy feeling. Sometimes it washes over them, it's gone, and that they felt it once, and that's it. That person that only felt it one time, that's included in this 90%. 50% of those that experience nausea are going to experience vomiting. Sometimes that might be they've had one episode of vomiting in their entire pregnancy and they got over it and everything was fine. They're going to have frequent nausea with less frequent vomiting, but it's still something that affects their daily life or their weekly life. It's important if she's responding that she has nausea and if she has vomiting, what is her current nutritional status? Is she able to eat? Is she able to eat 3-4 small meals a day? Is she staying hydrated? Or is she just avoiding eating and drinking altogether because she's so nauseated and every time she puts something in her mouth, she's throwing up? Our pregnant women should not be losing weight while they're pregnant. They should be. This baby growth requires work. It requires building blocks. They can only get those building blocks through a good diet. They should not be losing weight. If they are losing weight, we have got to intervene. Sometimes sipping some herbal teas will help that. And if you notice on this, I've got carbonated beverages kind of in italics. For some women, the carbonated beverages is just enough to dilate their stomach because of all the bubbles in there, that when they burp, they actually regurgitate a little bit. Maybe not actually throw up, but it's enough just to make them burp up some of the solids in their stomach. Others, that carbonation helps settle their tummy and helps that nausea and vomiting go away. So sometimes we just have to help them experiment with that. Acupressure bands, things like C-bands or acupuncture. If you notice up here where we talked about herbal teas, it says ginger herbal tea. Another very effective way for a lot of women to deal with this nausea of pregnancy is ginger. I've taught this for a long time with newly pregnant women. I would have classes on the things that they need to do to maximize the health of their pregnancy, what they can do about some of these common signs and symptoms. And I would always tell them about ginger. Having ginger cookies or ginger snaps. From what the women are telling me, the ginger snaps that are the hard cookie have more ginger in it, so it settles them more than a softer ginger cookie. That's just free advice. I don't know. That's based on what women have told me. That's not based on any research or anything that I've read somewhere. Avoid sudden position changes. Sometimes this nausea is so bad first thing in the morning that the best thing we can tell them is don't brush your teeth until lunchtime. Oh, but I got to go to work and, well, you know what? If you brush your teeth and you end up throwing up and you can't go to work, or you wait till you get to work, things kind of settle down, maybe you can brush your teeth as soon as you get to work. If it's severe, we allow her to eat whatever they can keep down. This is usually for a very short amount of time to help get them over the worst of this. So maybe for a week, the only thing she can keep down is ice cream. Now, this is not an excuse for all pregnant women to go eat nothing but ice cream. But if that's the only thing that she can keep down, it's calories, it's calcium. Yes, there's a lot of fat in it, but it will keep her from losing weight. At least there are some building blocks. Now, we don't want her to have a steady diet of that. Way too much fat, way too much sugar. One of the hospitals, I think it's Brigham Young University hospital. No, it's not. Can't think of it right off. Anyhow, they have an entire floor where women have been so nauseated that they have to be admitted because they have to have IVs and fluid and electrolyte replenishment, and maybe some of them so bad that they need TPN so that they have the building blocks that they need. Their philosophy is whatever mom wants, whenever she wants it, that's what she can have. And for some women, for whatever reason, one of the strangest combinations that tends to settle their tummy for some women, salt and vinegar potato chips and lemonade. Now, I, in my right mind, would never eat those together. I love both of them, but I wouldn't have them together. But if that's what it takes, are we saying that we want her to eat that for 40 weeks? Absolutely not. Is it okay this week while she's trying to get over the worst of this? If this is the only thing she can keep down, absolutely. We do want to make sure that we're not talking about anything harmful. Avoid all those smelly foods, tuna, garlic, curry. Even if they absolutely love those, that's just too overwhelming right now. We may need to get rid of that, especially during this first trimester. Once they get through that first trimester and that placenta starts taking over the production of some of those pregnancy hormones, for most women, that nausea and vomiting goes away toward the end of their first trimester. Have them avoid any odors that tend to make them nauseated. That can be the coffee. That can be, the aftershave of somebody. You know what? I just can't tolerate that. I'm going to ask you not to wear that. Or at this moment for the next couple weeks, I probably can't come to work if you're going to wear that. And most women, most co-workers will stop wearing that perfume, stop wearing that aftershave for a few weeks to help a co-worker get through that. But this is also important at home. Like the laundry. Sometimes, we don't realize that laundry smells, but moms have super noses. So they can smell everything, and the smell of the laundry just does them in. If that's the case, then take the laundry out of the bedroom. Put it someplace else so she's not smelling that all night long. We talked about the urinary frequency. They should be taking in at least 2 liters of fluid a day, with the majority of that being water. We certainly don't want 2 liters and more of Coke, of all juices. Although juices are healthy, we certainly don't need a full 2,000 mLs of that every day, because that's way too much sugar typically. Make sure that the path on the way to the bathroom is clear and lighted, because she's going to make multiple trips at night. Some of our other common discomforts that we have: fatigue. They're so tired. They are just inexplicably, they just can't put one foot in front of the other. And again, sometimes this is most severe in that first trimester. You're building up all that extra blood supply. All this massive work of bodybuilding and baby building and placenta building. They're just worn out. And it's like, I just got up. All I did was go to work, and now I come home and I can't move. It's okay to take a nap, but we have to caution her about taking too many naps. If she comes home from work, I don't know who comes home at work at 4, but say you came home at 4, we don't want her to take a nap from 4 to 7, 7:30, because then that throws her night routine off. And then it's just a kind of a self-fulfilling prophecy. But do lay down, do take a nap. Don't feel guilty about a nap. And a nap should be about an hour or so. We talked about that increase in vaginal discharge, the nasal stuffiness. Not much you could do about those. Those are just things that are going to change. The edema of pregnancy. If she stands all day at her job, she may need to do something where she stands and maybe has a case of water or soda under her desk or under her wherever she's standing, so that she can alternate putting one foot up on it so they're not flat. If she can take a break and go put her feet up for 5 minutes to help with the circulation so she doesn't have so much edema. And then certainly when she gets home, put her feet up and rest in the evening. Varicose veins. Sometimes this is very bothersome for some of our women, and so we would want them to wear support hose if this is an extreme case. And if they're going to wear support hose, we want them to wear at least thigh-high support hose. We do not want knee-high support hose, because with the edema of pregnancy, we have knee-high support hose on. We're actually compressing the system, so we put her at greater risk for blood clots, but not if we're talking about thigh highs. Hemorrhoids, very common problem because they're so constipated. They're straining so much to go to the bathroom. So let's fix the constipation. Let's make sure that we've got her on a stool softener. If this is an issue, make sure that we're telling her, make sure she increases the amount of fluid, make sure she increases the amount of fiber so that she's not so constipated. Backache and leg aches and leg cramps. Sometimes this is a matter of posture. Sometimes the leg cramps are because of this fluid shift. So again, resting, putting your feet up, resting with your legs elevated. The backache, help them realize how their posture has changed throughout this pregnancy. Have them sit up straighter so that they don't have such poor posture that's causing backache. Insomnia. They're so fatigued, but they can't sleep. And I know as nursing students, you understand that concept. You're so sleepy, all you want to do is lay down and go to sleep, but your brain just goes round and round and round and round. Maybe not even about anything specific. You're just feeling really stressed, so you can't get yourself to calm down and relax enough to actually fall asleep when you've got time to sleep. Round ligament pain. Round ligament pain is pain that's on the sides of their uterus. And the best place I can tell you is if you think about mom sitting down and her distended abdomen sitting in her lap, if she were to put her hands underneath the protuberance of her belly, she's probably going to touch about where those round ligaments are. Now, round ligaments in a non-pregnant person, they're about an inch in length. And they're holding that uterus suspended in the pelvis. Well, those round ligaments are now stretched way up to the top of where that uterus is. Might be way up underneath her ribs. So those ligaments are really stretched, and they can have some significant discomfort and pain because of those round ligaments. So we tell them to lay on the side that hurts, because what that does is it kind of helps support the ligaments on that side by shifting the contents of the uterus over, so we take some of the stretch out of that. Well, that can really stretch those ligaments on the upper side, the side that's going to be up if she's laying on her side. So we want to make sure that she has a pillow or something underneath her stomach while she's on the side, so that it also supports that abdomen, so everything in her entire abdominal contents has not shifted all the way down to the bed when she's laying on her side and pulled the opposite, or those upper round ligaments. I hope that makes sense. Carpal tunnel syndrome, because of the edema, because of all this extra fluid, sometimes they have carpal tunnel syndrome. Travel. Women, this is part of our anticipatory guidance to help her understand what she needs to do to help keep her safe. Make sure she knows she's supposed to be wearing seat belts and shoulder belts while she's in the vehicle. Pregnancy is not a reason not to wear a seatbelt. The lap belt needs to be under her abdomen. That shoulder belt needs to come between her breasts. Now, women are really uncomfortable with that, so they put that shoulder strap underneath their arm so it's not coming across their chest. That is not protective in a motor vehicle crash. That needs to be on their sternum because that's what's going to take the brunt of a collision, and that's why the shoulder belts are so important. If she's got it under her arm, then she's got it across her ribs, not across her sternum. And so in a motor vehicle crash, that belt is going to break ribs, lacerate what's underneath there, and that's not good. Frequent breaks for walking are important. If she's on a plane, she needs to walk from the front to the back of the plane every couple hours. If they're traveling long distance in a car, we need to stop and take a break. It means that they're not just going to kind of wander into the gas station, wander over to the bathroom. It means they're going to power walk into that bathroom. They're going to power walk around the parking lot and then get back in the car. We want them to move those muscles in their legs to make that blood flow move so that we decrease the risk of blood clots in their legs from sitting. When they're sitting, we need to make sure that we tell them not to cross their legs. If there are no complications, travel is usually not restricted. If we're within about a month of mom's due date, most docs are going to tell them that they need to stay pretty close. If we know they're going to travel, we know that they're going to, mom's house, which is, 9 hours from here for Christmas, then maybe she needs to take a copy of her prenatal records with her, so in case something happens while she's away from here, she has her records so that she has them available should she need to go in to see somebody while she's away. So, critical thinking question. What factors are we going to consider when we're talking to a mom about her exercise while she's pregnant? And exercise is important in pregnancy. So ACOG says that regular exercise, ACOG is the American College of OB/GYN surgeons. So this is the professional organization for OB/GYN docs. They say regular exercise is beneficial. After the first trimester, we're going to avoid supine hypotension. We're going to modify aerobic exercise and do non-weight bearing exercise. Avoid injury or exercises where loss of balance might result in injury, such as like stairs, step exercises. Sometimes because their center of gravity changes so much, some of those elliptical things might be a little bit harder to do and might be better avoided. Avoid overheating. We don't want her out there power walking around the neighborhood in August when it's 110 degrees in Texas. Ensure that she has adequate fluid and fiber, and that she's eaten before she's exercised, not immediately before, but that she's getting good calories to support this exercise, and that she has a continuous intake of fluid while she's exercising. Pregnant women should be able to carry on a conversation while they're exercising. So if they're walking around the block or they're walking around the mall, they should be at the height of their activity, be able to carry on a conversation. And if they're having to keep taking a breath while they're walking, their intensity is too high. And if they're having that much trouble getting their oxygen, then they don't have enough to get to baby. So they need to decrease the intensity of their workout or slow down their walking. We want their pulse rate at 140 beats per minute or less, because any more than that, we're going to have trouble getting good oxygen stores to the baby and able to pick up his waste products. Wear a good supportive bra and shoes. She's carrying extra weight while she's pregnant. She needs better shoes. She needs a better bra. She needs maybe to wear support hose while she's doing this if that's a necessary thing for her. We want her to stop exercising immediately if she exhibits shortness of breath, is getting dizzy, has any numbness or tingling any place in her body. If she has pain anywhere, she needs to stop. If she has greater than 4 contractions in an hour, she needs to stop. She needs to sit down. She needs to hydrate. Those should go away. If not, she probably needs to call her provider. If she notices decreased activity either during the exercise or she notices after she walks around the block every night that she comes home and she has a period of baby not moving like normal, that's probably a sign that something's not like it needs to be, so she probably needs to report that to her provider. And then if she has any vaginal bleeding or an increased type of discharge like her membranes might have ruptured, she needs to be evaluated. We do encourage mom to get exercise in preparation for childbirth. Things like modified sit-ups help tighten those little abdominal muscles so that she has good muscles to help push with. Pelvic tilts. Best way I can tell you to do the pelvic tilt is if we think about this baby and this big tummy kind of protruding, and mom has this big sway back because of this protruding abdomen. Think about rolling those hips in so that she straightens out her lower back, and think about pulling that baby and her tummy into her core a little bit more. That actually strengthens her back muscles and helps strengthen her pelvis. Kegel exercises or Kegel exercises, depends on where you were born and raised. Those are the exercises that we teach mom. The best way to teach her how to do this is tell her to start urinating. In midstream, she needs to stop her flow of urine. That's a Kegel. So she needs to do those. She needs to do about 10 of those, several 2 or 3 times a day. That strengthens her pelvic floor so that she can hold the baby in there, but it also helps her identify those muscles that she's going to have to use for pushing and to relax to be able to push. Now, Kegels can be done any place. They can be done sitting in class. They can be sitting in traffic. They can be standing in line at the grocery store. Kegels can be done any place, and nobody around you needs to know that you're doing them. They should not be, 1, 2. If it's that obvious, somebody's probably not doing them right. And then just learning for some relaxation. Thinking about where her body's tense. Thinking about where she's holding her muscle tension and letting some of that go. And relaxation isn't so that she doesn't use her epidural. I don't need to learn that. I'm getting my epidural. Do you think there's any time after the birth of this baby that a mom might need some relaxation exercises? When baby's crying, we've changed the diaper, we've fed them, we don't know why they're crying. So in order not to get all worked up and anxious over this, I'm just going to sit here and deep breathe for a minute. When that baby goes to kindergarten that first day, I need some relaxation. They start to drive, so this is not just so that they don't get their epidural. This is a lifestyle thing. I bet some of you students need this as well. Sexual activity is perfectly okay during pregnancy unless mom has history of preterm labor, she has vaginal bleeding, her membranes have ruptured. Otherwise, unless she's been cautioned against it because of a health concern for this pregnancy, sex is okay and it will not harm the baby. In childbirth ed classes, I've had dads say, well, my nephew was born and he had a dent in his head. Was that because they had sex? That dent in the baby's head is called a soft spot, and it has nothing to do with sex. We talked about women's sex drives fluctuating throughout the pregnancy. Sometimes in pregnancy, sexual activities and positions need to be changed as mom's body changes. Maybe the normal missionary position with mom on the bottom may not be okay when she is 9 months pregnant. We might have to try some side lying or mom on top. We want to teach all women who are at risk for a sexually transmitted disease that they need to use a condom. We need safe sex if that's an issue so that we can protect the health of this fetus. Dental care. Hopefully mom's had prenatal care, preconceptual care. In the preconceptual care, we've told her to go to the dentist, make sure she gets all her cavities, any big dental work, she needs a crown, any of those kind of things. Get all those done prior to the pregnancy, because there is a correlation between bad dental health and some problems in the pregnancy. So let's get her mouth in healthy shape before she gets pregnant. If she hasn't had preconceptual dental care and now she's pregnant, we're going to tell her that we don't want her to have x-rays in the first part of this pregnancy. Hopefully not at all during the pregnancy, but if it's a necessary thing because of whatever, then we need to make sure that she is shielded, that that baby is shielded when they do those x-rays if it can't be prevented. And then extensive dental work we want to delay. Immunizations, some of them are okay during pregnancy, others are not. If she's had her preconceptual health care, hopefully we've gotten her the immunizations that she needs prior to getting pregnant. While she's pregnant, she can get the hepatitis B vaccine. She can get the inactivated flu vaccine, Tdap, meningococcal, and rabies. The things that we do not want her to have while she's pregnant are anything with a live virus. So the flu vaccine that has the live virus, an MMR, we do not want to have. That can be detrimental to this pregnancy. Varicella, typhoid, or meningococcal. So what are some of the adaptations to this pregnancy? We call that cognitive restructuring. It occurs over the course of the pregnancy. It's talking about how this baby, like we said, is going to change everything in her life. How her relationship to her childless friends are going to be. How the changes in her friends that have children. She's going to grow closer probably to those who have a similar experience. So she might get closer to those that already have children, where there's a little bit of distance between the ones that are still out partying and still running around and don't have kids. Emotional lability is very, very common in pregnancy. They have mood swings. They're so excited and they're laughing, and before you know it, they're crying. Oh my gosh, I don't know why I'm crying because I feel really good. And then all of a sudden she's back up again. That's hormonal. That is not a psychological problem at all. This is very, very normal. Very normal in the very early part of pregnancy, and again as those hormones change right prior to approaching labor and delivery, so in those last couple weeks of pregnancy. Ambivalence, very common. They even are women that have gone through years of infertility. They've spent all this money getting pregnant. Now that they're pregnant, they're, oh my gosh, I don't know if I'm ready. What did I do? What am I gonna do? That's very common. It does not mean that they're not bonding with this pregnancy. It does not mean that this is an unwanted pregnancy. It just means that their emotions are all mixed up, and now that they're pregnant, oh my gosh, what did I get myself into? Different phases that mom goes through. Phase 1, I'm pregnant. And so she views the child as part of herself. That's part of who she is. A lot of introspection. What do I expect? What am I going to do? How is this going to affect everything? And then phase 2, I'm going to have a baby. So the baby is no longer part of her identity. This is starting to be somebody different. She's becoming more and more aware of this baby. 1, because her tummy is starting to distend. 2, because she's starting to have signs and symptoms. 3, sometimes just hearing the fetal heart tones at that prenatal visit. Oh my gosh, this is real. This is actually happening. That ultrasound where they actually get to see their baby. Again, a period of introspection and then moving to acceptance. And sometimes because mom is introverted and really thinking about this, her partner may feel really left out. We always did everything together and I feel you pulling away. They're probably not pulling away as much as they're trying to figure out what they're going to be doing. Other children notice these changes in the household, so they may become more demanding. Potty trained kiddos can all of a sudden not be potty trained. Normal change, there's big changes in their environment, we expect some of that. And then phase 3, wow, I'm going to be a mom. Mom starts to really visualize what this baby's going to look like, who they're going to look like, how everybody's going to interact with them once they get here. And then they get ready for the safe passage for this newborn. They start preparing the nursery. They start figuring out which hospital they're going to deliver at. They're going to figure out what they need to pack to take to the hospital. Who's going to take care of this baby if they go back to work. Start getting all those things lined up here. Active participation through education. A lot of them start taking childbirth ed classes. What are they going to expect? We have to help women understand that prenatal classes are not to teach them how to breathe so that they don't use an epidural. Not everybody gets an epidural the minute they get to the hospital, because what if anesthesia is in the OR? So how are we going to help them through this time frame when they can't get their epidural? How are they going to know when they're supposed to come to the hospital? How do they know what to expect during labor and delivery? How do they know what to bring? How do they know how long they're going to be in the hospital? Do they know what entrances to come in after like 10 o'clock at night? Are certain doors in the hospital locked so they can only get in through this one certain door? That's what prenatal or childbirth education is all about. They have a lot of anxiety about, are they doing their best thing? They're worrying about whether they're going to be a good mom. Are they going to be good parents? Do they have a good, safe household? So our dads also go through a big change. They have to start accepting this pregnancy. They too might be very ambivalent. They initially, they want to get pregnant. Oh, yay, excited. They are pregnant. And then all of a sudden, oh my gosh, what are we doing? Are we ready for this? So they may be ambivalent as well. They're going to negotiate their role in labor and parenting. And we want to encourage mom and whoever her significant other is, whoever's going to be a part of child rearing with this child, that they actively talk about what their expectations are for each other. A lot of times the expectation is mom's going to change all the stinky diapers and the other person's going to change just the wet diapers. Or that mom's going to get up and do the 2 a.m. feeding and I'll do all the ones when they're awake. Well, that needs to be negotiated. A lot of times their active involvement in this pregnancy and they start fantasizing about what this baby is going to be and they start thinking of themselves as a father. Now, it's not uncommon that dads connect to this pregnancy at a little bit later time frame than mom does. Mom starts connecting early on because she's the one going through the physical changes. And so dad, a lot of times, don't really connect to this child until her abdomen starts being distended. Or they actually start seeing fetal movement. Maybe not until they see ultrasound pictures of this baby. And so they might be involved in choosing the family name or the child's name. They may have Covad syndrome. I'm not sure if I'm saying that right, but they actually have the same signs and symptoms that mom had. They're nauseated. They have a backache. It's because they're empathizing so much with her that he's experiencing the same symptoms. And that does not mean psychopathology on his part either. So siblings, how do they adapt? 1-year-old, they're unaware. They don't realize anything and their environment's changing. Toddlers may become more clingy and may regress, like we said. 3 and 4-year-olds, interested in their own beginning and in that baby. Well, how'd the baby get in their tummy? How come mommy's getting so fat? How did he get in there? We don't need to do the birds and bees discussion at 3 to 4 year old because they don't really want to know all that. All right. School age might be more clinically interested. Adolescents might have difficulty thinking about mom and dad being pregnant because, oh my gosh, gross. That means that mom and dad had sex. And what are my friends going to think? This is awful. My parents are having sex. Most adolescents think that mom and dad have only had sex. How many of her kids there are in the family? If there's only 2 kids, mom and dad have only had sex twice. Grandparent adaptation. Evidence that they are getting older. Sometimes a grandmother too soon. If she was 17 when she got pregnant and her 17-year-old daughter is now pregnant, she's a grandmother at 34. And I'm not ready for that. Grandparents transmit the family history, the knowledge, the experience. They may bridge that gap between the generations. Kind of help the older family relate to the newer family and the new fandangled ways we have to take care of these new babies. And then it's a maturational milestone all on its own. We take great pride in picking out grandparents' names. Nana, Mimi, Nana, as opposed to grandmother. And that's the end of this slideshow. We'll finish up this week with the lecture on nutrition. Have a great week.